On episode 18, we interviewed Dr. Mike Kirlew on Indigenous health, and we're going to just get straight to it. There's not going to be no hype. There's not going to be no kids doing the intro because this episode is too important. There's just so much to learn here. And I'm going to ask you guys a favor like I often do, but truly, if you can share this episode, listen to the whole episode. I know it's 60 minutes, but there's so much to learn and to be aware of about Indigenous health that is just striking. Like, imagine a community of a small community, Indigenous community that loses 4 12-year-olds to suicide. Imagine knowing that your education needs are 30% less funded. Imagine if you're delivering a baby from afar, you're not able to bring family along to support your care. Things that we know matter that aren't happening to our own people. Okay, I just need you guys to please listen and share this episode. And yes, this episode's less about solutions, but more about increasing awareness. But we do need to increase awareness, and it is not all doom and gloom. We talk about some of the initiatives that are happening locally in Sioux Lookout, for example, that are inspiring and creating change within those communities. But once again, this is a must listen. As Canadians, as North Americans, I want you guys to leave this thinking that we need to do better. What's going on up north is wrong. Okay. So without further ado, Dr. Mike Kirlew. I am talking to the one and only.
Oh, please. Not the one and only.
The one and only.
Oh, please. Oh, please. Stop
Dr.
that.
Mike Kirlew.
Stop
Dr.
that.
Mike Kirlew. Listen,
Exactly.
we were so eager to get this guy on the show for a few reasons.
Listen.
One, he's an angel.
Oh, please.
He does amazing work.
You did not
north.
say that you'd say that.
No, but it happened.
Please.
And
You did
then
not say that you'd
second
say that.
thing, without mincing words, you got to talk to us and inform the people about the atrocities that you see up north. Because I don't think people really have a clear picture of what you see at Sioux Lookout and other places. So I think the best way to start us off is maybe just talk to us about a day in the life of Mike Kirlew.
Mm-hmm. Sure. And you know what? I want to say it's great to be able to be here. I think you're doing a phenomenal job. I think your whole team is doing a great job, really kind of being that voice in the healthcare community, getting a whole bunch of different opinions about different topics. I think that's really good. So I want to congratulate you for doing such a great job. You know what I mean? I've known this guy since residency. So you know what I mean? It's good to see you doing such amazing work. My name is Mike Kirlew. I work, up in Sioux Lookout, Ontario. Sioux Lookout is about 450 kilometers or so northwest of Thunder Bay. Our practice, I work with an amazing group of colleagues, and I want to say a shout out to all the good people in Sioux Lookout, all the wonderful doctors and nurses. I work with some phenomenal people there, and our practice cover an area the size of Germany and France. Wow. So all the way over Hudson's Bay coast, all the way over to the Manitoba border. So it's about the size of France, and there's a number of Indigenous communities in that area, and the doctors in the region fly to various communities and provide care. We also provide care in Sioux Lookout. When people get sick in the communities, they often will fly down to Sioux Lookout to be able to get care. So when you're in Sioux Lookout, you're doing a little bit of everything, right? Like it's rural medicine, you know what I mean? And when you're up in the northern community, you are doing, again, a bit of everything, right? You're seeing pediatric patients, adult patients, you could see really sick kids, really sick adults. But I want to start off by saying, I feel really blessed to have had the last 13 years to be able to work in such an amazing place and then really meet phenomenal people. I'm going to be moving on from there shortly and stuff, but I really feel blessed by having an opportunity to work there, and just feel that my life has been sort of super enriched by meeting some amazing people and having the opportunity to learn from elders, who I consider my teachers, right? Wow. And just learning for some amazing patients and clients that have taught me phenomenal things over the years, right? I see a lot of, and I don't want to start this off because typically when you get these talks, it's like, man, we got so much of this and we got so much of this and we got sepsis and vancomycin. I'm not going to start off like that because, a lot of people have an idea what we're going to talk about today. But I'm going to talk about, I see a lot of hope. Mm-hmm. I see a lot of resilience. I see a lot of people waking up every morning, figuring out how to persevere, right? Figuring out how to have hope and how to inspire hope in others. Mm-hmm. In the face of unbelievable circumstances and unbelievable tragedies, still waking up and saying, you know what, I'm still going to press onward, and I'm still going to press onward for my community. And I find that that's so amazing. That's so inspirational to be, I feel so inspired to be able to bear witness to that, you know? And I think that is awesome. You know what I mean? And I want to acknowledge that, you know, because I do see a lot of hope, and I do see that, you know, a lot of change and a lot of community advocacy that's happening, you know what I mean? Around how can healthcare outcomes improve, right? You know, I always say when you work sometimes in a rural environment, one of the things that I've learned is that medicine isn't only about content, right? Like in residency, right? You're always trying to master the content, right? You know, you're trying to understand, you know, how do I interpret my blood gas? How do I go about, you know, interpreting this piece of medical information? How do I go about synthesizing all this lab work and coming out with a diagnosis, right? So it's not only about the content, it's also about the context, and the right answer in the wrong context isn't necessarily the right answer anymore, right? And we have to, I think, understand how colonization has introduced a context, and having systemic racism and having unconscious and implicit bias within our healthcare system, and how colonial systems are structured, how that really impacts health outcomes, right? You know, I see a lot of, for example, infectious disease complications, right? We still see a lot of rheumatic fever, right? Like you hear about rheumatic fever, you think about, I remember in med school, you know, hearing about, you know, having the cardiologist say, man, you're never going to see this again, right? Like this is something that you just don't see in this country anymore, right? And we still have, you know, we've had deaths in our region of little kids with rheumatic fever, right? Kids. Yeah. So we've had deaths in our region because of rheumatic fever or complications of rheumatic fever. So it's not something that we see uncommonly, right? So when you just let that marinate for a little bit, right?
Yeah.
Like rheumatic fever is something that we remember, like our grandparents may have talked about, right?
Yeah, like we definitely don't see that.
Exactly. Like you don't see rheumatic, like, but like, you know, if you have like a kid with a swollen knee and you tap their knee and there's no bacteria, it's probably rheumatic fever. Like that's my line.
Because this is what I'm saying. Like when I was talking with some other folk, it's like you're literally dealing with third world medicine, like things that you weren't supposed to see anymore.
Right.
You know, and I guess what I want our listeners to understand is, first of all, like how bad it is, but like, why is this happening? Like, are you seeing a kid with a swollen knee and it's not because he injured himself, it's because he's got rheumatic fever, a disease from
rheumatic freaking fever.
Yeah, exactly.
You know what I mean? Like this stuff makes like pediatrics rounds. You know, if you're in some tertiary care center, this stuff makes pediatrics rounds. And like here it's like, oh yeah, they have rheumatic fever. Like, you understand? But you look at it, that these things are tied into, and we use this term and we throw it around there. It's called social determinants of health. I don't even like that term, social determinants of health. I call it like powerful determinants of health, because I'm seeing these things that we're about to talk about, things like overcrowding, housing, water being a problem, being like, these things are massive determinants of your health. Like for example, if we're dealing with a sequelae of a bacteria, right, that may live in the back of your throat, right, or may live on your skin, right, and you live in overcrowded housing, what's going to happen? Stuff is going to spread, right?
Yeah.
And then you're going to see a lot of sequelae and a lot of complications. And you throw in there inadequate access to clean running water, you're going to have problems. You're going to have lots of problems, right? And that's what I'm saying, is that, like, you know, you could have all the vancomycin in the world. You could get people, you could spritz vancomycin from the clouds. The clouds could rain. You could make it rain with vancomycin.
Make it rain antibiotic.
You could make it rain antibiotic. But you see, if you don't address things like housing, if you don't address things like water, if you don't address things like overcrowding, if you don't address things like colonization and racism, you always, because these bug, group-based strep and MRSA, like, published on this, like these things occur at a rate in the Sioux Lookout zone that's multiple times what it is in Southern Ontario in cities. And part of that, I feel, it's just, you know, overcrowding and housing and inadequate access to running water and housing.
No, I feel you, but once again, I want to get, because I've never been up there.
Right.
And I know a handful of docs that go on a regular basis.
Right.
But I want to get a sense from you, like when you say overcrowding, what does that look like? When you say, like,
you might have like 17 people living in a trailer that's like 600 square feet.
Wow.
Like, that's a lot of people, right? And you might be in a situation where they're describing where they don't have running water.
So what are they doing? Like,
you might have to go and get water from the lake and that type of thing and manually haul it over to your house. That's not an uncommon story. So imagine how something like that can impact health outcome. Imagine what kind of cases of eczema you're going to see in kids. right? Imagine what kind of skin and soft tissue infections you're going to see, right? Like you're going to see a lot of them, right? And you're going to see a lot of invasive type of infections, right? Invasive MRSA, invasive group A strep. Our physicians in the region have published on this before, like looking at things like group A strep and looking at things like MRSA. It just happens in multiple fold what you'd expect in a large city, right? So, imagine that. And think about it like this too. Remember, it's a different system, right? It's a federal system, right? So you got like federal nursing stations. So there's no like hospital in the northern communities, right? Like you're not going to have, because when you have a building with an H on it, an H means something, right? Like why is that important? Why is that powerful? Because it's not the letter. You can slap a letter on any building, but when you slap an H on a building, it means that there's going to be certain protections. There's going to be certain legislations. There's going to be some accountabilities that you're going to see in that building with an H on it that you're going to see that you're not going to see anywhere else, right? Yeah. Like that's why when you show up and you have a scalpel, you don't see the surgeon spit on it and cut you open, right?
Wow. So that's a great point. So like they're not being treated at a hospital.
Right.
It's a, what do you call it?
Yeah, like it's like a nursing station, right?
A nursing station.
And you know what? It like, and I meet, there are awesome nurses there, like nurses that just do their best, you know what I mean, in the circumstances that they have, right? Where oftentimes you may not have necessarily the right equipment. You may not necessarily have all of the essential meds that you need.
But this is part of the BS that irks me too, is like why, like I've gotten calls from you for transferring patients, and I'm hearing that you don't have the right antibiotic.
Well,
you might be running out of oxygen. Like what's going down?
But ask yourself this question, right? Like why don't you run out of oxygen at a hospital, or why don't you run out of oxygen at a health center? Is that there's legislation in place that gives you certain levels of accountability. Suppose if you were at a place that was devoid of that accountability, right? There's no federal health quality act. Like we have provincial health quality acts that guarantee that, man, if you're going to call yourself a hospital or a clinic, you need to meet certain standards, right? If you don't have that, then what do you think is going to happen? Right? Like you're going to be in a situation where you may not have the right antibiotic, right? You may not have a muscle relaxant. Like I listen to a lot of podcasts, you know what I mean, and stuff. And you like to hear, man. And it's amazing, like when people talking about, rapid sequence inhibition and get your succinylcholine and rocuronium, and which one is better? Is it sucks or rock? Sucks or rock? Sucks or rock? What does Weingart say? What does Ruben Strayer say?
So
you know what I mean?
Just to give the context, it's like the nuance of some of the medication to try and optimize people's health.
And I'm like, that's great for you to have that conversation, but I don't got none of that stuff there. I got no sucks or no rock. So imagine if you have to intubate somebody, that could be problematic. Number two, suppose if you only have 1 or 2 vials of midazolam and you need to intubate somebody, which is a medication, or you don't got no ketamine, or you don't have any propofol, or you only have 1 vial, because the thing is, the reason, what allows you that doesn't happen in a hospital, do you understand, is the legislation, is the accountability that you have in hospitals.
But even, and this is going to sound ignorant, I don't give a damn whether things are legislated or not. At some point, you got to ask yourself, like, what is right? What's going on? Like, I don't have. So what Mike was describing was core medication to be able to provide basic care in acute situations. So imagine that you got a loved one that needs to be put on needs help breathing.
You need to put a tube down their throat to save their life.
To save their life. Thank you for putting it so eloquently. You might not have that enough medication. So maybe they'll feel what's going on. Like they might not be asleep. They're going to feel that pain. They're going to potentially have some PTSD from that experience.
Exactly.
Like these are our citizens in a $1 billion or $1 trillion GDP country that are experiencing this shit.
Right. Exactly. And that's the thing. And that's a reality that we encounter on the regular, right? Because and if you think about it, it really underscores the effects of colonization, right? And the effects of systemic racism. Who is this happening to? This is happening to Indigenous people, right? In Northwestern Ontario, right? And, it's in class. It's not, it actually has to, we have to go up to be second class, right? Because I would consider you of second class, you're still going to have you're still going to have some basic equipment, right?
Like, wherever you are in mainland Canada, you have that access. You know what I mean? And I don't know, I guess, Mike, what do we do about it? What the, you know what I mean? Because and just to put more context into this, like how real it is, it's like I see people regularly from up north that are dying young. Yeah. For sure. Yeah. Absolutely. Like that's not just like some theoretical stuff that we're talking about. It's real. Like someone in their 40s that had terminal lung disease.
Yeah, exactly.
You know what I mean? Like it's insane.
Right.
And it's so tragic. You know what I mean? And
Yeah.
so this is like what we're saying. We see it. It's real.
It's real. It's very, very real. And, you're seeing really the effect, I believe, colonization and systemic racism, within all sorts of systems, right?
Mm-hmm.
Like that's what colonization wanted to do. Like colonization wanted to preserve differential care structures based on ethnicity and based on race. Like it would look and say, because you're indigenous, we need to take your land, right? And in addition to that, we're going to make sure that you don't get healthcare like how other people get. The accountabilities and the protections that other people have, you don't get. Like when you dial 911, right? What do you get? You can get an ambulance shows up, right? We have legislation that allows that to happen, right? We don't get an ambulance that shows up. You get a truck that shows up. And you put the person in the back of the truck and it brings the person to the nursing station, right? Because there's no ambulance act. There's no federal ambulance act. So there's no federal fire marshals act. There's no federal healthcare quality act. So if you don't have those protections in there, then what do you think is going to happen? A whole lot of badness, right? And I think as physicians, we need to start recognizing, well, what are the root causes of some of these things, right? Like,
amen.
We need to look at that, like, because I find sometimes as doctors, we get hung up. Well, all I need to do is figure out the right vancomycin titration for this person's MRSA bacteremia and why it's seeded to their sternal-manubrial joint. You learn about these bacteria seeding to some places, you didn't know that was a thing, right? Like, when someone says something, because I didn't know that was a thing. I'm glad I spoke to you, right?
All the time.
You understand? Like, I didn't know that was a thing. I didn't know that those things could seed to your sternal-manubrial joint.
Everywhere, man.
But when you see it happen, and you see it happen regularly, you got to start questioning, okay, why is this going on, right? Like, what's the treatment for this MRSA? Is it vancomycin exclusive, or is it justice, fairness, equity? I think we need to start looking at those bigger picture issues, right?
Do you know what's amazing, Mike, is I think I said this on a previous show, but you think about med school and the training we got, we do not address prevention at all.
We don't.
We didn't talk about social determinants of health at all. And before you go on your rant, the thing that is a pity about this is that docs want, at that age especially, they want to do better. They want to make an impact. So if I promise you this, more docs that are aware of some of these issues, especially early on in their career, they're going to act on that shit.
Exactly. And I think medical schools are, because I remember when I was in medical school, you got virtually nothing about Indigenous healthcare.
Zero.
I like to tell about the first time I drove. I went to Sioux Lookout. I was originally planning to work somewhere else. That fell through, and they told me, yo, there's this place called Sioux Lookout. It's up in the bush past Thunder Bay somewhere. You could work there. So I decided to go there. And I remember I asked the cab driver who picked me up at the airport, can you just show me around a little bit? It's a new town, small town, so they show you, you know what I mean? And they show you where the municipal office is, and they show you where the high schools are. And I remember they had 2 hospitals, right? So I'm thinking, man, Sioux Lookout's doing well. You got 2 hospitals, right? At that time, right? At that time, there were 2 hospitals. There was a 7th Avenue site and there was a 5th Avenue site, right? So 2 campuses. I'm just like the Ottawa Hospital, right? You got Civic and Riverside and Jettering, you know what I mean? You're doing good, Sioux Lookout, right? Yeah, you know what I mean? But I remember the cab driver, I was saying, man, I asked them, man, how come this town has 5,000 people? Why are there 2 hospitals, right? In my naive brain, right? I'm trying to comprehend what I'm seeing, right?
Yeah.
I always say in life that, profound moments don't just happen when you get some answers. It's when you start to ask the right questions.
Amen.
Do you understand?
Oh,
hallelujah. Praise the
Sweet 6-pound baby Jesus.
Sweet 6-pound baby Jesus. I know. So so you start asking those right questions. So I remember the cab driver had looked at me and said, the reason why there's 2 hospitals here is that there was a town hospital, and I saw it and I said, okay, that's cool. So why do you have this other hospital here? And he's like, well, that was the hospital for Indigenous patients. So I said, excuse me? Did I hear right? It's like, yeah, that hospital was built back in the 50s, and it was the Sioux Lookout. Back then it was called the Sioux Lookout Indian Hospital, right? So I'm thinking okay, hold the phone 1 second. How come I didn't know about this? And how come I didn't learn about this in med school? That we had, because whenever you think about segregation, what does our mind always go to? Yeah. Those darned Americans, right? We think about segregation from the civil rights context experience in the United States, right? But we have a history of that in Canada.
Oh, big time.
We have, and as I was learning, and you learn about wonderful community leaders, like one of my personal heroes, Josiah Fiddler, who held hunger strikes in the 80s to protest the care Indigenous patients were receiving. And you realize that. That happened in the 80s.
That's not that long ago.
That's not that long ago. So do we have an understanding? Like our med students taught that. Like, are you taught that if you go, there was not just in Sioux Lookout, there was in Moose Factory, there was all these hospitals just for Indigenous patients. So we had, even from back then, a system that was designed to be inferior. Wow. And it triaged people based on race to inferior care. And this is not a system that ended 100 years ago. This is a system that persisted until very recently. Now, it's interesting. If you go to Sioux Lookout now, we have a beautiful new hospital, right? They tore down the old 5th Avenue site, right? The 7th Avenue site, the old quote-unquote Indigenous hospital, is still standing, but it's not used as a hospital anymore, right? We have a beautiful new hospital, right? The Minoyawan Health Center, which is a beautiful, beautiful building, right? But you see, like, look at that legacy. Do you understand? Like, look at that legacy that you had, kind of differential care.
Oh, and the thing is, it lingers.
And no one, exactly.
And it's like, it's, you know, you move on, but those attitudes, mindsets, that's embedded.
That's embedded. And that's the thing. It's what is in the DNA of the system. That's what we need to understand. What is in the DNA of the system? Remember, the healthcare system, as it was conceived to treat Indigenous people inferiorly. It was structured but separate, but unequal care based on colonial principles, right? Which are riddled with kind of these notions of racial inequity, right? It's deep, and you know, you got to get into somebody's DNA, right?
Yeah.
You know what I mean? When you get into that DNA, when you kind of get into colonization's DNA and realize that we have to make sure, are we taking that look inside the mirror as physicians, as practitioners, as nurses, as allied health, and saying, you know, there could be a little bit of colonial tea in all of us, right?
Yeah.
We've all been steeped in a little bit of colonial tea, whether we like it or not.
I mean, you get exposed, the attitudes of your preceptors, the attitudes of all those around you. Like,
exactly.
You know, sometimes by not being as aware of it, we don't really know about we're not cognizant of our own biases and behaviors.
Exactly.
You know, like the ironic thing too is we're doing this it's Black History Month.
There you go.
And as we're talking, I'm like, there should be I don't know, maybe there is, and forgive me if I'm ignorant, but Indigenous History Month, like about like, especially in our country,
right?
You know, and just increasing the awareness of some of these atrocities and some of these embedded behaviors, attitudes.
Right.
Like I'm still a bit baffled that this was 1980 and this was still present. You know what I'm saying?
Exactly.
But you were mentioning too, we weren't getting any information on this in med school. I don't even know. What about undergrad sociology? All this stuff within like Canadian history.
Canadian history is totally devoid, right?
You know what I mean? Like it's so bad.
Right. And when you think about it as well, right? Like when we kind of look at and we think of segregation, we automatically think of the United States, right?
Yeah.
We think about the United States and the experience that African Americans had, right? And other groups like segregation, right? We don't realize that there were systems up here that did the same thing, that persisted way after the U.S. stopped its organized segregation.
Oh man.
Just think about it. Like you couldn't have segregated hospitals in the States in the 80s.
Yeah.
Do you understand?
Yeah.
So like I'm
could,
saying,
but
like,
you couldn't.
We need to, you know, I think we need to understand that. I think we need to kind of each take a look at ourselves in the mirror and say, like, where are our unconscious biases, right? Because we've all been steeped in a little bit of colonial tea, whether we like it or not, right? And how we improve ourselves is to realize what those biases are, right? And then effectively address them, right? It's not to pretend that they don't exist. Do you understand?
But it's like we don't, kind of the purpose of this show is like to increase awareness, to increase that conversation.
Right.
Because like those biases, they can be so embedded in it and innate that you absolutely do not realize it going on. Right. And until you have that conversation, it's in front of you.
Yeah.
You know, nothing will change.
Exactly.
Man, like it's like I said, it's just really hard when you see preventable diseases with young people of your own nation and just get destroyed as a result. Bring it back to just some like personal stories.
Yeah.
Are there any times where you, in the last few years, where you thought to yourself, like, you know, enough is enough? Like when you think back at some of the patients that you had, or
like to give up, you mean? Like enough's enough?
or like we gotta do better, or
yeah. You know what? I think it started like, you know, when you start practicing, you're like, okay, I gotta, you know, I have all this medical knowledge to attain, and I gotta go to all these CMEs. I call it the nerdy stuff of medicine. You know what I mean? I gotta be continuing medical education. I gotta be able to interpret blood gases that much better, and you understand? So you spend, but then you realize that, man, I'm seeing a lot of endocarditis.
Yeah.
And you're like saying to yourself, the big question is the why.
Yeah.
Right? Like, why? Like, are we spending enough time? And then we start looking and saying, well, there's overcrowding because there's inadequate housing. There's no running water. Like, there's some communities that have been in boil water advisory 20 years. Would that be acceptable in any other context? And you ask yourself that question, like would it be okay if there was a neighborhood in Ottawa where let's say they built new homes and they said, you know what, for the next year, y'all gonna be on boil water. Don't worry, we'll give you a little credit. You understand? Like, but you'll have to be on boil water. Do you think people would do that for a year? You think they could do that for like, imagine if you never had like for 25 years water that you could drink out of the tap.
You know that would never fly.
That would never fly.
What's that doing to your soul, by the way?
Pardon me?
What's that doing to your soul?
You know what? Honestly, I have met and I've had the privilege of meeting some amazing, amazing patients and clients. And I'm telling you, that resolve to overcome is contagious.
Wow.
Do you understand me? Like, it's a resolve to overcome, right? And sometimes I've been with a position where I was like, listen, man, that is it. Like, this is just
too much.
This is just too much. Do you understand? But that when you see that hope and you see that just resolve to overcome, that resolve to kind of not give up, that's inspiring. And not to lose hope, that is inspiring. My patients teach me that. They have hope.
Wow.
That hope is contagious because you can be in a situation like we have very little access to mental health resources, right?
Wow.
Very, very little access to mental health resources, right? The community that I provided care at, you know, Wapaki, we lost 4 12-year-olds to suicide in 9 months. And the place only has a population of like 500 people. So just imagine, that's like half on imagine if like in 9 months, one school year, in one high school, 10 kids committed suicide. And like that's what we're talking about.
We're talking 12-year-olds.
12-year-olds.
Like usually 12. If you have one 12-year-old in the outer, it goes on the news like crazy.
Exactly. And it made because it's like, and you know what? The community, and this was well documented and well publicized in the news, the community had put forward community-based solutions 6 months before the first suicide because they said, listen, man, there might be a suicide pact. We want to be able to get counselors and get the support systems that we need. And they did it 6 months before, and they gave their proposal to the federal government and said, yo, we need some help. And we're going to come up with a community-based solution, right? 6 months before, you know what they were told?
What's that?
It's an awkward time in the funding cycle. And then 6 months later, guess what happens? You get one suicide, and then a week later, another one, and then a few months later, another one, and then a few months after that, another one. 4 young girls.
Oh my God.
So think about that. The community 6 months before, they said, listen, man, something's going down. Do you understand? We need to work on a community. They did their end. Don't tell me if there was a school, if there was a high school in Ottawa and they said, yo, man, there's a suicide, there's something going on, there's doing that, we're concerned, they would get more resources. But imagine if you've articulated that as a community and you said, listen, we have a concern. Do you understand? And we're going to put forward our proposal to get additional resources to develop community-based solutions so that we can deal with this at the community level. Imagine you told us a bad time in the funding cycle. And you know what? Exactly. You can link this. There's articles written about this. And this is just from 2017, man. This is 2017. Listen, the federal government, when you think about this for 1 second, Quado, think about this for 1 second. This is a struggle for basic rights, my man. Basic rights. Think about it. Look at in pregnancy. You know what the number one concern of women in pregnancy was? That they don't deliver their baby by themselves.
Oh my God.
Because think about it, like you're in a northern community, you have to come to Sioux Lookout or Winnipeg or Thunder Bay to deliver your child, right? The government wouldn't cover a partner, a support person to go down with you. So you would be expected to deliver that child by yourself. Let me ask you a question. Could you go right now in the hospital on the maternity, I saw the labor and delivery floor. Could you go on the labor and delivery floor? Tell the partner, we're about to have a baby up in here, so you need to leave the room. While we could, they would be like, excuse me? Can you think of one other procedure other than a C-section that we allow the partner in the OR? We allow a medical trained person in the OR while a surgical procedure is going on. Can you think of another thing to do other than a C-section? Why? Because even in we recognize that you get tons of positive outcome by having partners, support people sharing that experience. And think about that rule. And you can link this in the show notes. This has all been well documented. Just got changed in 2017. Ask yourself that question. Wow. Like, that's basic, right? Like, that's, people sometimes ask, Meg, what is the healthcare system that's the cherry on top? And it's like, sometimes, man, my patients don't have the cherry on top. They don't even have the table that the cake is sitting on. Do you understand what I'm saying?
Can't get in the room.
Do you understand? And I'm just saying, look at that. Now, you know what? Communities fought for that, and now they've changed the policy, right? So I credit the government for changing that policy. I think that's good. But man, like 2017, 2018, we're talking about having a birth support person in the room with you. We mastered that 50 years ago.
And like, what's the age? What would you say was the average age of some of these young moms?
Well, it can vary. Right? Imagine you being 18 years old.
Exactly.
Like, because once you're an adult, they'll cover it for a kid, right? So if you were like 17 and pregnant, but imagine if you're 18. No, you don't get escort. You're 18 years old. And where are you delivering? You know what would be really sad? You know what would be really, really sad? Let's say if that baby, you're delivering that baby and that baby develops respiratory distress, and you now have to go to Winnipeg Health Sciences Center with that baby, and that mom just had that baby by herself, now going off to the ICU by herself with no support person.
Oh my God.
So no, that's the real. This is for real.
Communicating with
exactly.
Like, who's at support?
Exactly.
Who's going to help settle her fears?
Exactly.
Completely foreign environment.
Exactly.
Those anxieties often translate to poorer outcomes. Oh my God.
There you go. Right. So that's what I'm saying. It's like, we need to get the humanity in this. Do you understand me? Like, that's what we need to remember in medicine, is that we're dealing with human beings, right? And this is what colonization and inequity does, right? It takes out the human being out of the equation. Do you understand?
They're not being seen as
being seen as a human being. Because if you look at it, when colonization wants to steal people's land and the land belonged to somebody else, what it just did is devalued them as people. Do you understand? It said, well, you're not just not a person, or you're just not as good as me, so I can just take what you have and there you go. You better just like it, right?
You're not an equal.
You're not an equal. That's what it's telling you. Colonization every day is telling you, you are not equal. Well, I can take what belongs to you, and you do not deserve, based on your race and based on your ethnicity, you do not deserve the same things that I have.
And think about
your life does not matter.
This might sound a bit extreme.
Yeah.
Imagine, like, would we accept that kind of behavior with our pets?
Oh, very good.
You know what I mean?
Exactly.
Like, I don't know, man.
I know.
It's debilitating. It's dejecting.
Yeah.
Hearing this shit. I mean.
But you know what? Like this is what I'm saying. That's where I don't want to leave you feeling dejected and rejected, right? Like, I don't want to leave you feeling that way. I want to leave you thinking that, you know what? In spite of that, I see hope. In spite of that, I see communities' resilience. I see communities banding together to come up with programs, to come up with community-based solutions to surround youth with the help that they need, elders with the help that they need. So that's coming. So I don't want to leave you with this doom and gloom, because, I don't want to leave you with that, right? I do want to make sure you understand the real. That if you think, and this was just, you know what, you can link this to the show notes. All this has been published. It was on CBC, all those types of stations that covered all of this. So if people don't believe me or don't believe, that's fine. They can read about it there. And this is all recent, man. This is from
real news.
You know what I mean? And stuff. This is from 2017, 2018. You know what I mean?
Yeah.
And
I mean, I got so many things to say. Like, one thing I do want to say is, it is nice to hear the pushback, that resilience.
Yeah.
Because, if there's one thing that I've learned from what you see from people that come out on top eventually, is that at some point you just say, we're going to put it in our own hands.
Yeah.
We're going to,
There
we're
you
not
go.
going to wait for our assistance, or if no one's coming to help out, we're going to do what we can do
There you
within
go.
our own community to make some
Right.
shit happen.
Exactly.
You know
And
what I
that's
mean?
a power of self-determination.
Yeah,
Right?
and
Like
that is something, unfortunately they're in a position that's what's necessary, but it's good to hear that there's some positive coming out of that.
Exactly. And I think as clinicians, we need to be real. We need to take a good hard look. Just like the nation has to take a good hard look, everybody has to take a good hard look in the mirror and say, where is my implicit bias? Not if I have implicit bias or if I have unconscious bias, but where is it?
Where is it?
Especially as clinicians, right? Because like you're making decisions every single day, right?
Mm-hmm.
And that can change the trajectory of a patient that you see in a very profound way, right? So we need to understand where our implicit biases are, where our unconscious biases are. We need to understand what colonial frameworks are, that colonization is embedded in our healthcare system, our criminal justice system, the child welfare system, right? And these systems were structured to affect certain people certain ways.
Yeah.
And I think there needs to be a knowledge and an acceptance and an understanding that those systems are at work, and that the acknowledgement and an understanding that those systems are at work, and also to recognize within ourselves, well, how can I deal with the implicit bias that I have? How can I be an effective ally? You know what I mean?
And the other thing too, you mentioned before, is let's get back to the human side of medicine, man.
There you go.
Like I honestly, y'all maybe heard me preach this before. Like, you spend so much time, as you said, what does that blood gas mean? What is that? How do I diagnose XYZ?
Exactly.
But you always got to remember that's somebody's loved one. That is another,
Exactly.
that could be you in that spot.
Exactly.
And just, I don't know, I do think as I'm getting older, this is the stuff you realize how much this matters.
Right.
That how much that, having that humanism in medicine really at times is actually everything.
Exactly.
You know what I mean?
It's being able to connect with people, other human beings, and like putting yourself in the position that if that was your grandparent, like one of the things that we don't have is we don't have long-term care beds in the community. So even the big ones, the large ones, there's no long-term care beds. So suppose if you're an elder and you're 85 years old, and I'm sending you 600 kilometers away. And there's no road that connects those two spots. You have to fly, and flights are expensive. So imagine if that was your grandma or your grandpa, and we're in Ottawa right now. And imagine if I said, yo, man, I'm sorry, but they're going to go into London, Ontario, which is about 500 and some odd change kilometers away.
But you can't drive there.
Right. But you can't drive. But no one would say that that's acceptable. If you were to do that here right now, people would look at you and say that is unacceptable. There's no way.
Dude, people will complain if it's across the city. If it's not close to the...
But look at the standard in our region, where the standard is you go away, you go far away.
Yeah.
You go far away. And you have that full knowledge in your mind that the next time you may see your home is when you pass away.
Wow.
No, seriously, you just put yourself in that framework for a moment, right? Because it's all about being real, right? Like medicine, number one, has to be real. Yeah. Right? Take the blood gases out of it. Take all the, you know what I mean? It has to be real. We are human beings connecting with other human beings, right? Yeah. So how would that make you feel? Put your grandmother and your grandfather in that situation, just like I've done. And I'm just saying, snap, that fucked up.
Yeah.
And just to think that we're not talking about an isolated incident where that only happens like 1 out of every 100 people. That's the that's the norm. Yeah. And imagine if you're dialysis, what does that mean? Like if you can't, like you are far, you're going to be in Thunder Bay, you're going to be in Sioux Lookout, you're going to be hundreds of kilometers away from your home. Suppose if you need complex continuing care, you're going to be hundreds of kilometers away from your home. Imagine how that affects your mental health. Imagine how that affects, man, I'm lonely. I haven't seen my family. Imagine if you're 85 years old and you spent your whole life in a community and you're all of a sudden 600-700 kilometers away from home, away from your family. How are you going to feel? Just take everything out of it. Put your own grandparents in that position right now, because that is going on right now. How would you feel?
And you can't tell me that's not going to affect how the outcomes
Very
of the
good.
patient.
Very good.
When you've lost that hope, you've lost that drive, you've lost that community.
Exactly.
Mrs. Nelson, can you get out of bed to help to get your strength up? Hell no.
No, exactly. And I'm not saying like people can make a choice. Maybe sometimes you might want to go there, but like that's the rule. Do you understand? Where everybody, really, man? I wonder how many people right now in this hospital, if I were to do a survey, the amount of people in long-term care or waiting for long-term care, if a bed popped up in Sudbury would say, I'll take that bed. They know no one in Sudbury. Or a bed popped up in London would say, yo, I'll take that bed in London. Or Windsor. Yo, I'll take that. No one. Because they're going to say, well, it's basic. The basic premise of this is that you want your elders close to familiar spaces, close to their family. That's something that transcends culture. But that's what colonization does, right? And you see, it can operate covertly. It can operate overtly, but it can get dangerous too when it operates covertly. Because you can have these systems.
I think that's when it's most dangerous. Personally, the covert shit.
Exactly, yeah.
When it goes under the radar.
When it goes under the radar. And you can have these systems operating that are oppressing people like that, and we don't know. And that's what I'm saying. Like, you know, indifference is a motherfucker. Do you understand? Like, you see, if you can have people suffering and you have everybody else indifferent to that suffering, that's a motherfucker. That, like, it doesn't matter how many tweets you send out. It doesn't matter. And that's what colonization wants to do. Colonization is a motherfucker. That's what it wants to do. And how do you fight that? How do you have to acknowledge what's going on, right? But you also have to say, well, how can I deal with my own implicit biases? How can I address that? By growing up in this country, you are going to hear certain things about Indigenous people. They're not going to be in textbooks. They're not going to be, you're going to hear through popular culture, and it can shape the way you think subconsciously. And then if it shapes the way you think subconsciously, then when you become a clinician, it can affect your decision-making process.
Absolutely.
And you don't even know it.
Like I said, which is the most dangerous
Very
thing.
good.
You know what I mean?
Systemic racism, its child is unconscious bias, right? It wants to give birth to that because it means that you can get lots of indifference, and lots of indifference means you become immune to others' pain. So it doesn't matter how many times it's tweeted out or how many news articles, you switch the channel. You swipe right. Do you understand? And we have to make sure that we put these issues front and center. We do not treat people fairly. We need equity, justice, and fairness. They're dealing with TB in the Arctic. Are they recognizing the housing issues in the Arctic? Let me tell you something. If you don't correct housing, you're going to have TB. And TB is going to outsmart you. Because TB, it lives on inequity.
Oh, man.
And it can outsmart any infectious disease expert because it mutates and it doesn't. And people have been trying to figure this out for years. And then if you think you figure that out, then you get MRSA. And then if you think you can't figure that out, you get group A strep. And then you start getting other things. So let me tell you, man, a little bit of inequity that can overcome a whole lot of ingenuity.
Wow.
Little bit of inequity can overcome a whole lot of ingenuity. A whole lot of it can overcome PhDs, MD. You understand? MDs, just a little bit of inequity. Double doctoring.
No, and it's true. You know, because one of the platforms, the reason I do this is to increase awareness and what have you. But that indifference piece,
right.
that element of being, you know, swiping the other way or putting your head the other direction when these issues might come to the forefront. That's a huge obstacle. Right. That indifference.
Right, exactly. And that's what colonization, I think, ultimately wants. It wants, you remember, it's an effective oppressor, but it's also an extremely effective indoctrinator. So we can indoctrinate everybody else to be indifferent. So it's like you can go see a country overseas and you'll have more sympathy and more desire to do something than for something happening in your own backyard. Remember, everything that I'm talking about, the people's health card look the same as you or I.
They're, essentially your neighbor.
Exactly.
Yeah.
So I'm just saying, like, how are we understanding colonization? Are we understanding, anti-Indigenous racism, how that impacts health outcomes? Are we understanding that we can all be steeped in a little bit of colonial tea, whether we like it or not? That just by matriculating through this country, you can gain certain opinions and certain viewpoints of how you view other people. And do we understand that can shape the decisions that we make? Or are we going to say as doctors, no, we're all good. We're nice people. And I don't mean any wrong. Do you understand? Because let me tell you, man, we've all been steeped in some of that tea and we all need to, we need to acknowledge that it's there.
Can I ask you, what do you think is actually happening at like government level or at a societal level? Like, are we consciously ignoring a lot of this stuff, or are we at a high level, are people just being indifferent? Like,
well, that's what I'm concerned about, because like when I look at information now in the 21st century, like we can get information now faster than we've ever been able to get information before.
right.
You can tweet, something can be going down in Toronto, and as it's happening, someone's tweeting about it that you can find out about it, right? So we can get information now way faster than you could get at any other time previously, right? So we know when stuff happens. And these issues of housing and lack of access to healthy food and water insecurity issues and adequate funding for essential social services, like these are all well-established issues. So I would argue, like, is indifference rising?
Mm-hmm.
You know, 100 years ago when Dr. Bryce was talking about, you know, shutting down residential schools, because in some of the schools he reviewed, this is 100 years ago now. You can read about this in the history textbook. Actually, you can't, because they don't talk about this, right? So you won't read about it in your history textbook, and you probably won't be given a lecture about this in med school, right? But when he was told to review the health status of residential schools over 100 years ago, he said, you need to shut these places down because they're just breeding grounds for tuberculosis. And he was told, yo, man, you're fired, right?
Wow.
And that was 100 years ago. So that was just like, there was no Twitter back there. There was no Instagram back there. There was no TikTok. Do you understand? Mm-hmm. Back then, you couldn't get information as fast. So how do you justify the fact that now we have all this information? Now we have information that flows faster than it's ever flowed before in human history. But it's like, we don't care. So is indifference rising, right? We changed the channel, right?
Yeah.
I think we need to do some serious soul searching and, you know, looking at ourselves in the mirror, right? Mm-hmm. Every single person has to do that, right? Mm-hmm. And I think it's like that exercise of understanding, like, what is going on. Like, Canada did have like an apartheid, I don't even say apartheid, like it was apartheid, right? You know, system that persisted well into the 80s, right? Of healthcare, and there were hospitals for certain people and other hospitals for everybody else. And I wonder how that would affect people's interface with the healthcare system, right? Like, imagine when you see somebody here as an intensivist, right? If they went to one of those Indigenous hospitals 40 years ago when they were still open, I wonder how that's going to affect how's that going to, when you interface with the healthcare system now?
Wow, Mike.
You know what I'm saying? Like,
yeah. Truth bombs all over this.
That's
bad
what I'm
boy.
saying. Like that's what I'm saying. Like we just need to keep it real, right? And like, you know, but that's what I'm saying. Like, I've seen so much hope. Like, I have met some amazing people, like literally bring me to tears sometimes. Do you know what I mean? With the stuff they describe, but then it brings you to tears of joy or when you see that perseverance.
Yeah.
Like, it literally, you see that perseverance, that willingness just to keep on fighting. Do you understand? And coming up with ideas and supporting their communities in just powerful ways. That is powerful. Do you understand what I'm saying?
No doubt.
That is just powerful, right? Like,
wow. There was maybe one issue that we touched on, but I wanted to just really hammer home. You know, the mental illness is a huge part of like of our society in general, and it's increasing awareness. And,
right.
But it's clear that in the Indigenous population, it's a problem.
Right.
And I feel like it's a growing problem.
Right.
Do you see anything improving despite some of these community efforts? Or
you know what, I do, because, you know, now there's a big movement in the region of health transformation, and that's been exciting to be involved in. Health transformation, moving from a colonial system to an Indigenous patient-centered, community-centered system.
Yeah.
So you're starting to see that process happen, right? Of refocusing the healthcare on the individual and the community, right? You know what I mean? And focused on community values. And I think it's amazing to see that and to see the ideas generated, right? When you look at communities now have, you know, Choose Life, and there has been some articles about this, and it basically allows communities to be able to get funding to be able to implement and develop community-based solutions, right? Culturally safe, community-based solutions for looking at things like suicide in the community. And it's great to see the results. It's great to see the change in people. Do you understand?
Yeah. And
because communities know what are going to work for communities, right?
Yeah.
So it's great to see that those changes. So that's what I'm saying. Like the system needs to be fundamentally transformed. Like, incremental change ain't working. It needs to be fundamentally transformed, because if we just take the current system and just tweak it, you're tweaking DNA that's not good. Mm-hmm. And you're not gonna get something good. You need to completely transform. You need to change the value system of the system.
It's one thing I'm more and more, this theme has come up on the show. It's like change has got to come from the root. Like it's got to come from the people that are living it. It's got to people, that community.
Right.
And I think we got to really think about that. If we're going to be thinking about healthcare solutions in general.
Exactly.
It's got to come from the horse.
Right. It has to come from the people, right? You know, you got to have that change coming from people, and people need to be empowered to be able to get that change, right? They need to be supported and able to get that change. And it's amazing to see that when you have programs like Choose Life, where communities are basically funded to initiate community-based solutions. These are homegrown solutions that are amazing, that are phenomenal, that are able to take down suicide rates better than any psychiatrist or Western. You understand?
Yeah.
It's truly phenomenal to see. And like, we need to understand this as well too. It's just the impact of colonization, how it has had on that process of happening of self-determination, right? Because you were constantly told you ain't good enough. You don't have no value. Your life is no value. Imagine if you're a teenager right now and you go to, you don't have access to adequate education, right? Your school is funded 30% less than a student in your same grade down south. You turn on the tap and there's no clean water that comes out. When you dial 911, there's no ambulance that shows up. Or if there's a fire, there's no fire department that shows up. Do you understand? Like, how do you think that affects your mental health, right? What did we learn now what we learn now is that the amount of Indigenous people in federal penitentiaries is the only group that has gone up. So colonization means a consistently at your face is your life has no value. Imagine how that's going to affect your mental health. You don't have a school in your own community. You have to go out hundreds of kilometers to school at 13 years old. You should read a book by Tanya Talaga called, put this in the show notes, called Seven Fallen Feathers. It's a powerful book on how, you know, the education system, man, like we don't have enough time to talk about that. But, you know, keep in mind that if you have two students, same grade, the provincial system is going to fund their students 30% more than the federal system. That's a well-established difference, 20 to 30% more. So just imagine that for 1 second. And what are you doing? You're having differential fundings based on what? Race.
2020.
There you go. 2020. And that's happening now.
It's 2020.
That is happening now. And there still is a gap. And I always say, how come in the year 2020, we all like to act like we're so woke? We are so woke, we have to clear our throat because we choke on the wokeness. But yet we live in a system that right now is telling to Indigenous people that your kid, we give them 20 to 30% less than we give that kid, even though they're same grade.
Ain't right.
Do you understand?
Ain't
right. So I think, you know, we need to recognize these and, you know, do some learning and, you know, start asking the right questions. I said that earlier, you know, it's not powerful moments and not only when we get some great answers, when we start asking the right questions, right? Like when I was in that car, I was saying, why is there two hospitals in this place? I did not know.
Excuse me?
I had no idea. We didn't learn about this stuff in med school. I remember we got like one lecture. Do you understand?
This is why
how much did you get on medical school about?
I don't want to say with absolute certainty because it's approaching 20 years ago, but
yeah,
I do not recall any.
Very good.
And I did go to class.
There you go. Well, you see, my attendance wasn't all that, you know, my attendance, you know, wasn't all that spectacular, you know, but I don't want them to start, you know, questioning decisions off on things, you know what I mean? So, but I'm telling you, like, do we really understand? Do we really get that history? We don't get it, right?
Yeah. And there's many things to work on, but one of the things, you know, if I'm going to ask myself, what can we do to help is really, in my mind, support those community-led initiatives where the people are saying, this is what we need. This is how best we could be served.
Right.
And provide support for that.
Right, exactly. And sometimes your support can be, you know, as a doctor, you got a lot of privilege. Like we have a lot of privilege, right? Mm-hmm. And we do. And it's not to come in and say, well, you should do this and you do. We know that don't work. But what that support could be is to maybe provide your voice into like, listen, yo, the community has a solution here. Why can't
social
we fund
prescribing?
This? There you go. Why can't we look at this? Why can't we do that? They have an idea, right? It's adding your voice and potentially the privilege that you have with that voice. Do you understand?
Word.
To be able to move a community's agenda forward.
Yeah.
And I think that's something we need to recognize. We need to understand the history, because I don't think that that's taught enough in medical schools. I'm not sure how nursing schools, I'm not sure with allied health, but I have concerns about that. I do have concerns about that. Yeah. And we need to recognize our unconscious biases and our own implicit biases.
Well, Mike, I always try and end on a positive.
There you go.
What I mean? And so my question to you is, in your 13 years in Sioux Lookout, can you recall a time where you've really left an impression on a patient, or you've had a moment where you told yourself, this is where I'm supposed to be in this moment, helping this patient? Has any stories come to mind?
Well, you know what? I do have one, and it was around the time when the community had just lost 4 12-year-old girls, right? A few years back. That was an unbelievable tragedy, right? So imagine you're in a small community of a few hundred people, and 4, beautiful young bright girls commit suicide in the span of 9 or 10 months, right? And I remember I spoke to an elder, and that elder told me something I would never forget. They said, you know what, we're down now, but we're gonna be up again.
Wow.
And I'm just like, that level of hope, as I was saying before, is contagious. Like that is like, when you hear stuff like that, when it's like, there have been 4 kids that have just passed away because of suicide. And everybody would describe that as an unbelievable tragedy, right? Imagine if Barhaven had lost 4 kids in that period of time, right? Do you understand? And then this is a community of 400 people, right? But to hear the elders say that, we're down now, we're gonna be up again. You know what? One of the things people don't realize about that community is that there was a suicide crisis before, and they came up with a wonderful system, the Survivors of Suicide program, and community-based crisis teams that would go in, and all that got birthed from that previous tragedy, right? Mm-hmm. So it was like that elder just reminded that degree of hope, and never lose hope, right? Never, ever, ever lose hope. And that's something that I learned from that patient day. And that has been an extremely profound moment, when it happened a few years back. You know what I mean? And it will stay with me for the rest of my life. On just, that is an example of humanity right there. Wow. That example of to persevere, because everybody, like, you're feeling like, I am gone. Like, I felt like giving up, honestly. Yeah. If I just be real to everybody, I'm like, like you feel like giving up. But when you hear somebody say, you know what, we've down, but we're going to be up again.
We will overcome.
We will overcome. That resolve to overcome. That is powerful. Wow. That is powerful. When you meet somebody, you just see that resolve to overcome. You were like, shit, that is some like powerful stuff. Mm-hmm. That's some shit that you like take home that night and you mull over in your brain and just say, what the hell did I just hear? Mm-hmm. And it just sort of, it's powerful. So that, yeah, man, that sticks with you. And you know what? I remember that because that is just like a fine example of humanity right there.
Yeah.
You know what I mean? And those are the memories I will take. You know what I mean?
And I think that's a good place to end, because I feel, honestly, that is such a powerful message in general. Mm-hmm. That for us to put things in perspective and realize we can overcome.
Exactly.
We can do better.
Exactly.
There is hope.
There is hope.
Yeah.
Right?
And certainly I feel like after this conversation, I realize there is some hope.
Because you think about it, what does colonization want you to do? It wants you to give up on hope.
Yeah.
Not to have hope. Don't believe that anything is going to change. Believe it's going to go on like this forever. But what that elder taught me is like, you know what? You can be in the face of tragedy, and it can try to break your spirit, and it can try to do all those things, but it can't take your hope. That's something you have control over.
Wow.
Do you understand? And she made that choice that day, that even though in a situation that is adverse and is hard and is painful, I am making the choice to hope, because hoping is a choice. It's not a feeling. It's a choice you make. And she's making that choice to say, you know what? We were down, but we're going to be. And it's not, she didn't say she might be or she may be. She said she will be up again. They are going to be. The community will be up again.
She knows it.
There you go.
I love it. Mike, my man.
Good.
This has been amazing. I cannot wait to release this bad boy, because
oh my God,
you threw down some knowledge, you threw down some
just
truths. You know what I mean?
I don't know about that. I don't know about that.
But we're gonna have to have you on again. And thank you for doing this.
No.
This has meant
Anytime.
a lot to
I think,
us.
as I said, I think the work that you are doing and your team is doing is absolutely phenomenal. I've learned so much from listening to the podcast. It's great to hear. It's great to hear perspectives, and I just want to encourage all your listeners to just start asking those questions. Why? Do you understand?
That's another good truth right there.
I'm gonna leave everybody with something else that an elder told me, right? And this kind of blew my mind. If I could share this for 1 second, absolutely. Right? Is that this elder told me, and I've shared this before, that she goes, Kirlew, how do you measure progress? And I say, well, if you were over here and you move over here, and so she's like, yeah, it's kind of like measuring distance, right? Like you measure it in like inches or feet, right? And I said, yeah, to use an example, you kind of measure it in sort of inches and feet. And she says, you know what? I don't measure progress like that. I measure it in degrees. I'm like, degrees? Like, what do you mean degrees? And she says, you know what? The first thing you have to do when you decide to change is you have to point your eyes in a different direction. So even though you may physically be in the same spot, your eyes are now pointed in a different direction. That's the first thing you have to do when you're changing course. It's your perspective, right? Yeah. I'm just like, when I heard that from her, I'm like, that made so much sense. Because sometimes we get frustrated because, man, it's not happening fast enough and boom, boom, boom. But sometimes we have to recognize, just by looking at a situation differently, just by appreciating another perspective, just by asking the right questions, seeing things through a different lens or from an alternate perspective, man, you're well on your way to change, even though you might physically be in the exact same spot.
Wow, man. Truth bombs all over this bad boy.
Listen. Listen, man, that's not me. That is not me. That is not me. That is an elder that told me that.
You know what, though, dog?
And that's who you learn from.
Yeah, but how many people will hear, some people will hear these truths from whoever it might be, and it goes in one ear and out the other.
But you learn, you listen to people. Your patients, the people that you work with, communities, that's your teachers. It's not the person who's taught you how to interpret an ejection fraction. I'm not saying that's not valuable, right? But I'm just saying that, that's what gets you through life. Like, messages like that have helped me. When I learned from an elder that took a whole lot of wisdom and life experience and was passing that bit of wisdom, I'm like, that's powerful. That's powerful, because it means that, yo, man, if I can just look at the situation differently, if I can, that's the first step of change. If I can alter my perspective, even though my position hasn't changed, if my perspective does, then that's progress. Man, but you're doing a great job, man. You're doing a great job. We chatted for too long.
No, this is great.
This is great.
Thanks again so much for doing this, bud.
No problem.
Thank you, everybody, for listening. I know that's may have been an episode to listen to, but I really appreciate you guys taking the time. I want to thank our sponsors, BetterHelp, online counseling service that provides excellent care to those in need. Use promo code SolvingHealthcare, get 10% off. Sign up fees. Also want to thank our sponsors, Audible.com. If you sign up today, you get a free month and also help support the show through Amazon affiliate marketing. And I also want to just thank you guys for supporting the show through merchandise purchases. We've been able to raise some money for Ottawa Inner-City Health. I'll give the official numbers on social media. If you'd like the show, 5-star rating, please subscribe on iTunes, Stitcher, Spotify. We're all over the place. Get involved. Thank you so much. Leave comments at quadcast99@gmail.com. Follow us on Twitter, Instagram, YouTube at Quadcast. Guys, thanks so much for listening, and we'll see you next week.